All right, welcome everyone to our webinar, Rebuilding Trust in Science. A friendly reminder that attendees are not audible or visible, but you may ask questions through the Q&A function in Zoom. Also, this session is being recorded and will be available on the Hastings Center website later in the day for viewing with closed captioning. This is a special event based on the just finished special report published by the Hastings Center. I'd like to welcome Dr. Vardeep Ravitsky, who is the president and CEO of the Hastings Center.
Thank you so much, Brianna, and thank you all for joining. Trust is one of the timeliest concepts that we could be addressing today. As we emerge from the pandemic that showed us how critically important it is, and as we're entering the era of AI in health, recognizing how, once again, trust will be key to ensuring we're able to reap the benefits AI has to offer. So this special report that we will be discussing today showcases the role the Hastings Center plays in recognizing critical issues, in partnering and convening, in producing top-shelf scholarly contributions, but also in taking the last step of making these contributions accessible to decision makers and to the general public, which is what we're doing here today. So I'd like to thank the editors, Lauren Taylor, Greg Kebnick, and Millie Solomon, for their work in putting together such a comprehensive look at this critical issue. And I'd like to introduce Lauren, who will be facilitating today's event. Dr. Taylor is an assistant professor in the Department of Population Health at NYU with a joint appointment in the Division of Medical Ethics. Lauren, I'm really looking forward to today's discussion. Thank you all.
Thank you so much, Vardy. It's so fun to be here. I just can't tell you all, well, I will tell you all how long this has been coming. We started this over, I think, 18 months ago. And I've been joking with the authorship team that means that it took us twice the time that I took to incubate a whole human life, to incubate this special issue. So it's really fun to see so many of you on the line and get to share a flavor of what has gone into this work. So let me just offer maybe 2 or 3 kind of framing comments about the special report itself, and then also how we're going to try and broker a conversation today. The special report really came about partly through a joint effort between the ABIMF Foundation, that's the American Board of Internal Medicine Foundation, and the Hastings Center, who share an interest in trust and trustworthiness, and then was also supported by the Omen Fund at the Hastings Center. And the goal was really to lend some conceptual clarity, or to bring some conceptual clarity to a field that is notoriously complex, uses overlapping terms, uses terms that are differently defined by different authors. You know, trust to philosophers tends to mean something incredibly specific and narrow, and yet the way that we might use trust as a piece of speech at our dinner table or in conversations with friends can be really varied. And so there's a huge disconnect between the empirical literature on trust, which, as we know in health services research, the empirical literature tends to move fast because that's what gets funded. So there's a lot of empirical work that has really varied definitions of trust. And then you've got this like philosophy and to some extent a bioethics literature on trust that wants to really carve out a narrow definition, a workable definition, and a highly internally valid definition of trust. And so you face a real challenge when you go to literature and try and say, like, okay, we're coming out of a pandemic. We think we have something of a trust crisis on our hands. We want to build trust. What does the literature have to offer by way of instructive guidance? And the answer was like, not that much. And I really came to understand that firsthand when I was doing a review for Milbank Quarterly called 50 Years of Trust. And on the heels of doing that review, you know, I came to Hastings and I said, look, I think there's really an opportunity here to do some conceptual work for health policy, health services research, to some extent bioethics, in laying groundwork about how we should think about trust and trustworthiness and what some of the guardrails might be as we try and build these goods going forward. So that was the impetus and spirit in which we began the special report. We came to have this fabulous authorship. I believe there's 15 essays in the final report. You will hear from 5 of the authors today. And, I will say we were intentional about having a very disciplinarily diverse group and having a mix of methodological approaches. That carries with it all sorts of benefits. Like there's something for everyone in the report. If you're a social scientist, you'll find social science pieces. If you are more of kind of a conceptual theorist, you'll find those kinds of pieces as well. If you like p-values, there's a whole set of things there for you as well. But in doing that, it comes with challenges. I think we got to the end, and as successful as I think the report is, do I think that it has produced like a single unifying definition and conception of trust that we can just go forth with? No, I don't. And do I wish we did? Part of me does. And so I'm both like deeply interested and invested in exploring the differences that remain, because I think we did come to at least like significant convergence among the authors on what the key elements of trust and trustworthiness is. But it's not as if this is a consensus statement, right? There is still internal kind of disagreement or diversity of thought. And part of that is what we'll hear from some of our authors today. So with that, maybe, I should at least just say aloud who the folks are on the line here. And I won't give the formal essay titles because as each one speaks, I'm going to drop the link to their essay in the chat. But with us, we have 5 authors. We have Dr. Michelle Chow, who's from my home institution, NYU Grossman School of Medicine. Art Kaplan is also a mentor of mine at NYU Grossman School of Medicine. And then we have Dr. Leah Rand, who's up at Harvard, Mass General Brigham, whatever combination of word salad we're doing for all the Cambridge institutions at the moment. We have Dr. Melissa Creary, who's from University of Michigan, School of Public Health, and we have Deirdre Mylod, who's from Press Ganey. So the first question I'm going to put to my friends and colleagues who are the essay writers is just forget what you would say if you were going to a conference and you were presenting your essay. Tell me and tell the group who's with us how you would describe your essay to the Uber driver who's taking you to the airport. Like layman's terms, in a minute or two, what's the gist? And I'm going to ask this question to each of you. I put the order in the chat, so maybe we'll go Leah, Michelle, Melissa, Art, Deirdre. And just as a reminder, the follow-up is going to be, what questions do you have for one another? So with that, maybe I'll turn to you, Leah.
Yeah, thank you, Lauren, and thank you for this introduction to trust, because trust is important. And my Uber driver, and actually end up having these conversations more often than not on my way to the airport. It's really important that we trust our public health agencies. And one of those is the Food and Drug Administration, the FDA. And the reason why it's important to trust their decision-making is that they're approving the vaccines that we take ourselves and that we're hoping everyone else takes around us so that we're not transmitting diseases. And this was really called into question. If you cast your mind back to August 2020, there were political statements. We had appointees and elected officials making statements like, we'll have a vaccine by October, or we're going to have a vaccine really soon. And people started to get worried. What was the FDA going to be doing? Were they rushing through something? Were they holding to their usual approval standards that we all rely on to know that our food and medicines, or our medicines, are safe and effective? And we wanted to explore, when the FDA is taking actions that are so politically relevant and have political interests, what should it be doing to show that it is still to be a trustworthy agency, and to show the public that it's acting in trustworthy ways. So there can be a lot of interest riding in its decisions, and yet we have a lot of personal and public interest in making sure that it's trustworthy and making decisions that are right about what's safe and effective, or right for us about what is safe and effective. So in our paper, we outline 5 conditions that we believe it should be meeting, and these we set up so that in the next pandemic or in the next moment of emergency or political turmoil around one of their decisions, there's some guidance and some sense of saying we're holding ourselves to these standards for approvals.
Thanks so much, Leah. We'll go to Michelle next.
So if I were talking to an Uber driver, I would start off just telling him how we wrote an essay, my colleagues at NYU, and we wrote it with 3 members of the leadership at community organizations that we partner with in our work at NYU. And these are nonprofit organizations that provide educational, social services to minoritized communities in New York City, including Black, Latinx, Asian, and immigrant communities. So these were all our authors. And in our essay, we really describe how community-based organizations serve as trusted messengers to community members in different health contexts, and that they often deliver health information, they endorse health information from institutions, from government, they make referrals to health organizations. And we really describe how this happens and how trust flows throughout this process. We discuss why trusted messengers are needed, because of people's past, because of the reputations of these institutions in communities, because of individuals' past negative experiences with institutions, with physicians, with clinicians, because of political contexts. We describe why community-based organizations are really well suited for this role, because they're embedded within their communities. They're organizations that understand their cultures, their languages. They know strategies for engaging with communities. They work with these communities. And we also talk about in the essay, how they serve as trusted messengers and how this is accomplished. And we go through a couple of different ways that this happens. So we also talk about how in order for CBOs to serve as trusted messengers, there's also sort of these 2 layers of trusted relationships that are needed. There's trust between the CBOs and local healthcare institutions or academic healthcare systems. And there's also trust between the community-based organizations and its community members that are needed. And there's just trust building throughout both of these processes. So there's healthcare institutions that are working with CBOs to build trust. There's community members and CBOs that are working together. CBOs serve these community members. And then in the essay, we also go on to describe examples of programs from the CBOs that are authored in the essay. And we talk about how they leverage trusted relationships as well. So with Arthur Ashe Institute, we talk about the Barbershop Talk with Brothers, which is an HIV prevention program, where they work with barbers who are trusted in communities to provide health information. They train them. We discuss Make the Road New York, where they train community members to become peer educators and community health workers in healthcare settings. And with India Home, where they run senior citizen centers. And they also leverage trust through faith-based leaders that they work with and working with other trusted CBOs. So there's just trust trust sort of flowing throughout this entire process. And then we also just talk about at the end, we talk about how we learned several lessons from these programs, how they engage community members. They build partnerships throughout their communities. They utilize just culturally competent services, and they're huge advocates for communities. So that's sort of a sum of the article.
Perfect. Enough to whet the palate. Thanks, Michelle. Melissa, I'm coming to you next.
Yeah, thank you so much. So I am a very quiet Uber passenger, but if I were to be discussing this with my Uber driver, I too would start out by saying, I got this really great opportunity to write an essay with a colleague, Dr. Lynette Giardo, and we were trying to discuss the performativity of trust. And he might say, or she might say, well, what does performativity mean, right? And so I'd engage in conversation about performance, exactly what it looks like in terms of having folks kind of play lip service, give us a show of what they think we want to hear when it comes to these narratives around trust, particularly in these academic and scientific spaces. and the ways that it really does damage for the communities in which they're trying to engage with to collect good and meaningful data. And you can't collect good and meaningful data without that trust being very present. So we talk about the damage that gets done when trust is seen as a performance. And we talk about particularly the damage that's done to historically marginalized and minoritized community members, and the ways in which how this performance takes place is based deeply in values, and how often the values of those in the healthcare system and other systems are misaligned with the values of those in the community. And so we take a look at this kind of idea of performance through how we think about research inclusion initiatives, these attempts for research in academic spaces to be patient-centric without this kind of really deep and realistic look and an open conversation about social capital and power, about how we're inviting people to the table without really interrogating what it means to come to this table and what are these kind of broad socioeconomic, socio-historical factors that make them so enticing to be invited to the table to begin with. And we really are attempting to talk about how the only way we can get to the space beyond performance and into this area that it's restorative for communities is when we take the time to really sit with, be embedded with, and listen to communities about how deep, whatever that research question or intervention has to go. And so, we're trying to bring to light that this value misalignment can only correct itself when we start to have these open conversations about how hard trust building really is and the time that it realistically takes to build that trust, and then to understand when we do these kinds of superficial actions that the community understands and sees them as superficial, and how we can move, have a discussion about how we can move past that superficiality, past that performativity, into the space where we're doing really deeply embedded, engaged community work that takes the time that we often don't have. So it's a much larger structural issue that we're trying to get at, and unfortunately, all the interventions most of the interventions are surface level.
Thanks, Melissa. I have commended your essay in particular to so many folks because I often have an inbox full of people who are like realizing anew how important trust is, and you can't fault them. Like, it's a managerial instinct to say kind of, I want a quick win. Like, I want to show the community, quote unquote, how serious I am about this. Like, what can I do tomorrow? And it's just, you and I went back and forth on this, like in the line edits, I think, about your guys' essay is like, is there such thing as a quick win in building trust? And I think your response ultimately was no. We can come back to it. Okay, I'm going to come to Art next, and then Deirdre, you're going to round us out.
Hi, so thanks Hastings for doing this. Thanks Lauren and Greg for working on this special issue, very timely. So I got interested in this because trust in science, however defined, but people are polling about it, whatever they mean. But the polls show big declines in trust in science over the past few years, mainly fueled by COVID, I think, but other factors may be involved. I'm going to say, I think what they mean in the surveys of trusting in science and scientists, respect for their expertise, acceptance of their pronouncements as worthy of attention, and objectivity, that they're not trying to grind a particular axe when they speak as a scientist. And I'm sure there's 9 more values that we could introduce, but I think that's what the polling kind of thing is up to. So why is this slippage going on? I'm not sure anybody has fully explained why science is falling in the polling, and medicine too, by the way, not nursing as much, interestingly enough. And people still say they like their doctor, even though they don't trust doctors as much. There are disinformation attacks that are organized. We have a presidential candidate running on I think I'm going to suspend research on infectious disease for a while platform, RFK Jr., among other things. Disappointment with experts' pronouncements during COVID. People say they wavered or they flip-flopped or they weren't clear. Failure to engage at the grassroots level, where science communicators tend to be, is on national outlets, not at the local school board or church or mosque or Kiwanis Club. I don't think those audiences are getting much in the way of scientists, but they're hearing a lot from people who claim to have information worth listening to. And I have to say, and I'll irritate Lauren with this, but she can come back and argue with me, some more fundamentalist parts of religion see science as an enemy. This goes in and out from Charles Darwin to today. I'm talking more about the evangelical end than I am what's going on at the Universalist or Reform Judaism experiences. But there is this notion that science is positing truths and beliefs that people who are literalists about the Bible may not accept. And so that's got a lot of preaching going on about views of science that are, I would say, attempts to undermine science as the authority, as opposed to religious authority. Again, in part of religious outlooks, not by no means all. So why is the public susceptible to these attacks, if you will, whichever direction they're coming from? And I think it's because the public doesn't understand science. It doesn't know, as I tried to explain in my essay, what it is. Interestingly enough, I didn't say this quite as much in my essay. I'm not sure scientists know how to explain what science is. And I'm definitely sure, talking to my doctor friends around the country, they have no idea what to say that makes medicine a science. I mean, none. So you'll get answers like, well, it's about what appears in the New England Journal of Medicine, or it's definitely something that is evidence-based. And then you sort of push a little harder and say, well, what evidence? Like randomized clinical trials, testimonials, historical inheritance of tradition, and things fall apart fast. So my essay, in part, is an attempt to explain this issue. And I think my roots, and not in ethics, but as a philosopher of science, definitely have me oriented toward thinking one problem of trust with respect to scientific and medical experts is epistemological. That is to say, we don't know why it is that something should be valued because scientists say it or scientists publish it. So the first thing that people don't get is that science is supposed to be fallible. When you hear somebody say, well, you changed your mind, or you're not giving the same message, that came up a lot in COVID as the virus strain evolved, that's considered to be a weakness by many people. If it's true, it ought to be true for all time, not for 3 weeks. But at the same time, new evidence, new information, experiments that fail. As Karl Popper argued decades ago, falsification is one of the key striving attributes of science. So saying that what we say could always be wrong, or what we say could, in theory, be disproved, is not a sin. It's a virtue of science, as opposed to religion, which may sometimes say what we say is true, and there is no way to countermand it. There's no way to falsify it. It's clear from authority of our holy book. Second, disagreements do not make something not worthy of being called science. We're supposed to try and push and prod and challenge people's beliefs and the adequacy of their warranted evidence for those beliefs. But disagreement is something that people who want to attack science harp on right away and say, oh, well, look, the experts don't agree, so there's no reason to listen to them. They're all over the place. I'm not even sure they are all over the place most of the time. There may be a minority who have a position to hold out, and the majority don't. But again, disagreement is misinterpreted to mean you don't know what you're talking about. Scientists are willing to admit errors, other outlooks in life, whether it's art criticism or spiritual belief, may be less willing to say, I made a mistake, I have an error. But again, admitting error puts you at a disadvantage when someone attacking you says, I may not know anything about viruses, but I'm an authority. I'm here to say I've succeeded in business, and I've looked at all the evidence, and I've talked to Joe Rogan on his webcast, and I'm ready to say this is true. Celebrities did that a lot during COVID, saying, vaccines are harmful. And it was sort of like, where's that coming from? Science has another interesting aspect that people forget. It maintains a graveyard of bad and undermined ideas. That's what makes something science. You sort of look back and say, oh, never mind, no ether. Oops, nope, your ulcers are not caused by stress. It's actually a bacteria. Sorry, we were wrong. And that is exactly the kind of thing you want to trot forward, attention to history and showing how progress is made with respect to dumping bad ideas and acknowledging that they were bad and wrong. So those are all attributes, I think, fallibility, falsification. If you don't understand what science is, then when someone points out that you've got an error, you got a disagreement, or you admit that you had an incorrect position, well, that sounds like then I shouldn't trust what you say because you don't know what you're talking about. The big area, I think, that distinguishes science, which scientists forget about themselves, is that science is practical. It really gets measured in its ability to intervene in the world and obtain ends that people desire. So if I want to get to the moon, I do follow physics, and my physics is wrong if I consistently can't reach my goal. If I say I have a theory of disease, say bad miasmas, that is to say polluted air, that's causing disease, and in fact, there are plenty of people getting the disease where there's no polluted air, then my theory is not right. Or to put it another way, medicine is proven at the morgue. You say you know how to cure things, you say you know how to fix things, but if there are dead bodies stacking up, then you don't know what you're talking about. That practical side sometimes gets lost because scientists tend to be enamored with physics and chemistry as the underlying, and molecular biology as the underlying truths, neglecting the practical end of science, agriculture, engineering, medicine, veterinary science. Those aren't necessarily the sciences that are used to illustrate what makes the whole enterprise science. But the practical, in my opinion, is very, very definitive and needs to be explained to the public when they're up against disinformers or people who are just out to attack science. Just two more points and then I'll shut up. I think science can be communicated. I'm in the Albert Einstein camp of if you can't explain it simply, then you don't understand it anyway. But I think what's happened in the science community is it's done a horrible job of being able to talk to the public or the Uber driver or anybody outside the community of the science you're in about what the hell is going on. So nobody's trained to do it. More importantly, no one's rewarded for doing it. We've had a phenomena that dates from Carl Sagan, the astronomer who used to show up on Johnny Carson and other media outlets to explain astronomy and astrophysics, but he was never elected to the National Academy of Sciences. His colleagues basically insulted him for trying to be a public figure in science. If you think about COVID, a mass worldwide events, you probably can't get past 5 people on one hand who you could think of as spokespersons for science. You could easily get up to maybe 50 who were disinformers about science, and we're all over the place. So knowing what science is, I think that becomes very, very important. then being able to communicate about it becomes very, very important. But we have to start to reward and acknowledge that that is something that scientists who are good at it should do. And that is a duty owed back to the public who pays for much of the science, that they should take on that task. But I think they failed during COVID for sure. And that's part of the reason for the decline, I think, in trust in science.
Thanks, Art. As many of you on the line will know, Art writes about many things, but it was fun to watch him do an essay on philosophy of science, which I believe is like his first love. So, Deirdre, I'm coming to you to round us out.
Sure. So when I get into an Uber, often I'm going to an airport and people say, "What do you do for a living?" And I say, "Have you ever gotten a survey after you went to the doctor or went to the hospital or went to the emergency department?" And although Press Ganey does a lot of other things related to healthcare quality, that's what we're most well known for. So the paper is about what patient surveys can tell us about what patients talk about with regard to trust, and how clinician behaviors might influence trust. Although I've been very influenced by Dr. Cleary's article because I'm really struggling with the performative versus authenticity nature. But what our essay does is it looks at first, what do patients say about trust in the comments? And the things that we find, really high levels, first of all, that if patients talk about trust, it's almost always a positive thing. 92% of the time, they're saying something positive. So trust is both desirable and a good thing. And it's also something that is being experienced often. And then of the comments, when people talk about trust, more than half the time, they're talking about trust and immediately talking about their willingness to recommend. So they really tie together, at least in the narrative that they provide in a patient comment, they tie together, I really trusted my doctor, I would recommend her, or what you did made me not trust you, I would never recommend you to other people. That more than half the time, those concepts co-occur in the same phrase or the same insight. And then of the comments where they're not just specifically talking about recommendation, then most of those comments are specifically about caregiver behaviors. So the who that they trust is very important in what they want to talk about. And when we group the concepts, what is it about their care provider, their clinician, their nurse practitioner? What they're talking about most often is courtesy and respect, their skill and knowledge, and then explanations, listening, and reliability. And others have talked about, Lauren, you talked about in the intro that competence is necessary but not sufficient. Certainly, skill knowledge is one of the more common topics, but courtesy and respect comes up even more often. And we have a little bit of a sidebar in the essay that's just a fun finding that what we see is when people, when they talk about courtesy and respect and also experience humor, that can enhance trust. But if they experience a lack of respect plus humor, that can really reduce trust. So you have to really know your audience and know when it's appropriate to create the intimacy that humor can attempt to create. But we also look at not just what people say on surveys, how do they evaluate, what score or grade do they give to different behaviors, and then how do those relate to their intention to recommend, which we use as a proxy for trust. It's not exactly the same thing, but we know that it co-occurs very frequently. And what we find then with the hard data is that the things that are most likely to predict intention to recommend, and therefore I trust you enough to trust you for someone else, is confidence in their care provider, so that competence being necessary but not sufficient, staff working together, which we see as sort of together you will keep me from being vulnerable. I don't have to trust one or the other, but all of you together will keep me from being vulnerable in this scenario. And then the third comment or the third topic that comes up in those hard data analysis are communication and empathy, so the interpersonal relationships. So we look at the comments, we look at the key drivers, and the last thing that we talked about was that friction, the things that are not as important, wait times and accessibility and process things, frictions, they're not the most important things for trust, but they absolutely can erode trust. And the more friction that people experience, the less likely they would be to recommend an encounter because that trust has been eroded. So that's how I would talk about it to an Uber driver.
So great, Deirdre. And I just want to call out, lest you think that the writing is not just delightful in this special report, Deirdre and her colleagues have this great line on the humor point. In our analyses, humor, I'm going to butcher it, but humor is
a condiment.
As a condiment, not a main course.
Yeah.
And I just love that line.
I got to credit Tom Lee. That's him, all him.
It was great. I should also just call out your essay, Deirdre, for those in the audience who might be kind of into sort of nerdy quantitative methods. Deirdre and her team use this like fascinating natural language processing approach on giant reserves of proprietary data that only Press Ganey has access to. So it's really a very cool and special and fairly unique window into how patients deploy this term in their own narratives of their experience. Great. I just want to continue to encourage, we already have a whole bunch of questions kind of coming through the Q&A, but I am monitoring them and I am trying to respond to those that are easy to do. Just know if you're on the line, you want to ask a question, someone is actually eyeballing this and we will get to Q&A. You won't just be typing questions into a void. I'm going to turn now just to a couple follow-ups amongst the panelists. So I think, Melissa, maybe you had a question. We'll start there and then I'll come to you, Leah and Michelle.
Yeah, thank you. And thanks all of you for giving really great breakdowns of your paper for us. My follow-up, Leah, is I'm thinking about the FDA a lot right now. Friday, tomorrow, FDA releases a decision about CRISPR and what's going to happen for sickle cell populations, and I'm deeply invested in those conversations. And with my public health hat on and my former career at the CDC, I'm also thinking about these public health agencies that, you know, take on, I'm thinking about what CDC, like those public health essential services, right? And after COVID, those essential services got, you know, a revamping with equity dead in the center of that model of how we're thinking about what gets delivered and how we're thinking about public health in general. I definitely think COVID has changed all of that. And you're bringing to light that COVID should be changing the way we think about this, especially as agencies are trying to pivot and respond. And so with these two things in mind, this idea of, you know, how FDA is going to be releasing something that has a lot of questions around, you know, neglect for, or a response to historical neglect for a population like sickle cell disease, and thinking about how equity is being so kind of meaningfully and intentionally inserted in spaces. How do you envision equity as part of the framework that you're providing for the FDA as they move forward, as you suggest, within or beyond the 5 suggestions that you have provided for us?
Thank you. That's a really good question, and certainly equity. I don't want to be performative in saying this, that it's important within our organizations and institutions and as a consideration. And, you know, the FDA in something like vaccine approvals or this decision they're making tomorrow, and in our framework, we haven't explicitly addressed it. And I certainly see it in actions they're taking around clinical trial diversity and trying to understand, is there evidence sufficient to address a diverse population who will be the users of the medicines that they approve? And I think it's important too that their mission is different from the CDC. And so it's been kind of central to our view, our conception of the FDA and why we think trustworthiness is predicated on its review process and the integrity of that process, is that they're making what we hope are scientific decisions with some value informed about, you know, how uncertain can our evidence be? How great is the medical need that we're willing to accept more uncertainty? And that can make equity look really challenging when there is a large unmet need, but the answer isn't to approve something that isn't going to actually meet it, and to create either like false hope or potential for harm. And that's where I think the conversations and being connected to the public, whether, you know, we talk about connection to public preference when you're making a public health decision versus for the sickle cell case you mentioned, how important then it is that you have connection to that patient population to understand their specific concerns and where like they're willing to accept uncertainty.
Thanks, Leah. Leah, you actually had one right back at, I think, Michelle and Melissa. So do you want to fire away?
That's true. Thank you. So I read Melissa's paper and was really struck by the concept of bounded justice. I was telling her I just brought that up to a colleague earlier today who had a concern. And it also left me, and what you were telling us about is this kind of worried about what to do next, like how to sit with and really engage a community. And then Michelle, with your paper and working with these community-based organizations, I was just hoping to hear a little bit in conversation of how we do that work that sounds so challenging, of learning about and responding to an injustice in a non-performative way. And Michelle, that has come up in your work. Melissa, if Michelle's model is maybe what might be one step towards that.
Yeah, I really appreciate that question. Thank you. Because I think one of the responses to how we get beyond performativity is to actually engage with community-based organizations who, as Michelle has pointed out, are trusted messengers. So how do we then use kind of the CBOs as a conduit such that the alignment of values that sits with the CBOs and who they represent begins to get worked out with, you know, an alignment, hopefully, or a realignment, a readjustment from these structural spaces in the healthcare system. And so I'll yield the floor to Michelle to, you know, to enter that conversation. But it's exactly what you're positing, is that we have to depend on the trusted messengers to help break down and give us the space to create the meaningful trust that we're looking for the data.
Yeah, so I could speak to that a little bit. And I think Melissa's essay also kind of called out CBPR as sort of the action to kind of build trust. And, you know, I think our section at NYU, you know, most of our projects are community-based participatory research. So, you know, all of our projects are, you know, we're working on research projects with community organizations, you know, and I think I mentioned this in my essay too, you know, we fund them to be part of our projects. They're constantly a part of all the conversations we have in our project meetings. We have, like, you know, bi-weekly meetings with them, just discussing all of the research instruments that we create, getting their feedback on what community members think about, what their concerns are. You know, we're developing a proposal right now and trying to understand, like, you know, what sort of interventions they need. So, but it's a continual process. And, you know, I appreciated Melissa. There was a quote in Melissa's article also about how, you know, we do value CBPR in one respect, but we don't get as much funding, and maybe more funding is needed because, you know, having come from a non-CBPR background and then moving to NYU, I absolutely see the difference in how many resources are really needed for CBPR, and how, you know, I feel like we need more funding in this part, just because, like, you have to work with community health workers, you have to work with the community-based organizations, and that the work is just, it just has to sort of continue. But, you know, even that is not enough, because, you know, we've walked into, you know, research focus groups where we worked with community-based organizations to kind of recruit people, and I've had people walk out as soon as they hear that we're from NYU and that it's research. So it's not enough. You know, we're working with community-based organizations. The community-based organizations are working with these people in the community, but there's still that kind of like lack of trust that needs to get overcome somehow. And, you know, we're continuing to work on that, but, you know, I guess more needs to be done.
If I could just jump in on that, Michelle, because I just want to highlight both your essay with Nadia Islam and your colleagues, and there's another essay in the set that's about a different kind of community-based organizations, Artists, by Jill Sankey and Patrick Smith. That is also excellent, about the sometimes uneasy, certainly potentially valuable, but potentially tenuous as well, relationship between artists and public health systems and health systems. And I wondered if you would just say a word more, Michelle, about this risk that if CBOs are trusted in the community and healthcare is not particularly trusted in the community, by virtue of linking those two up, best case scenario, CBOs lend the healthcare institution some degree of trust, and it buys them time to do some authentic trust building themselves. Worst case scenario is that it bleeds the other direction. And healthcare, which is untrusted, now has robbed the community-based organization of whatever trust was previously there. And I just wonder if you have any experience like seeing that actually happen empirically, or if it's a concern for you guys in your work that you want to both be close to the CBO, but not so close to the CBO that you kind of defile them in the eyes of the community that you're trying to engage with.
Right. And I think you had asked this question sort of throughout the process as we were writing the essay. And
That's right.
I asked I asked the other authors about this as well. And they didn't say they necessarily saw that. So I don't know that we have any specific examples of that happening. But I also think it's just because the organizations that we work with, you know, are very well known in their communities and they offer so many different services. And I don't know, maybe that happens, you know, every once in a while. Like, for example, it could have happened when, you know, those people walked out because, you know, they didn't realize a research study was going to be happening, that type of thing. But yeah, I don't know that I have a better perspective on that.
Michelle, did you have something you wanted to put to Art?
I did. So Art, I really appreciated your essay and sort of the practical advice you have for, you know, scientists talking to community members. I was wondering if you have any kind of perspective on how sort of like political affiliations have kind of taken on a role in this sort of communication of science, and just sort of explaining sort of how that has happened. Because I was just sort of thinking about, you know, I was at a health fair a couple weeks ago, giving out materials for COVID vaccinations and trying to explain sort of the value of science and, you know, what makes it credible to somebody who didn't really believe it. And he sort of brought up his political affiliation and didn't seem to, like, you know, be interested in sort of the arguments about science and, you know, how the vaccines were made, things like that. So I don't know if that was addressed in your essay, but.
Well, it wasn't, but, you know, I think it's pretty clear that a lot of Republican or conservative politicians think of academia as left-wing, full of liberals. You can see it in the state of Florida as they try to reform their state university system. And there are many other private schools that are saying, you know, we're going to clear out this leftist bias in many of the departments. As scientists usually don't think of themselves as political at all in their professional roles. And a lot of them, in fact, don't think of themselves as political in any role. But, you know, they just sort of come up with evidence and publish it and move on to the next study. But I think the scientific community has not been very good about recognizing the politicization that has taken place. It's really of academia, and that's where most of the scientists and the doctors live, or industry, and that's where most of the conflict of interest charges live for scientists and doctors who work out of there. So I think we have to explain why it is that science can be trusted to be objective, no matter what its context, environment, or origins are, that the methods, that the peer review, that the willingness to subject the views to critique really help ensure objectivity. But I do think we've got a big phenomena of right-left, the right being more aligned with religion, the left being more aligned with science. And then you've got, related to that, a deep strain in American culture, which we're never going to solve today, but it's anti-expert. I don't need experts. I can handle things on my own. The rise of autonomy in COVID, I'm going to decide what's best for me. I don't need to listen to anybody about anything. That's a very powerful value that's not bred by COVID. It's been around It's the frontier mentality. I don't need experts.
Team, we're already at about 1:53, so I'm going to lift up a couple of the panelist questions, and then I'm going to close with asking each of you, like, what's one thought that you either want to underscore from your essay or a thought you've had since you did your essay? Because, you know, we turn these things in and they were done and dusted a while ago. So new thoughts are welcome as well. Deirdre, I want to come to you. Someone asked on the Q&A, and I think it's a great question. If, as you say, we generally conceptualize perceptions of trust as resting on adjudications both of a physician's competence and the something else, which you, I think, called courtesy and respect, what do you have to say about, are patients in a good position to judge physician competence? And like, that's a question I'm sure that shot through Press Ganey's work well beyond trust, but how do you think about that?
Yeah, it's a great question. And so certainly, first of all, the surveys are people's perceptions, right? And we're not all experts, to Art's point. But perceptions are often very directionally correct. And I'll give an anecdotal example. There used to be an inpatient survey question that asked skill of the physician, which wasn't even just confidence in that I have a reason to become, but I'm assessing your skill. It was not a popular question among physicians to see that for this exact reason. And at the time when that was on the inpatient survey, we had actually correlated inpatient data with physician engagement data. And the physician surveys asked them the quality of the medical staff at this organization. And one of the strongest correlations between what patients thought about their hospitals and what physicians thought about their work environment was the correlation between how patients assess the skill of the physician and what doctors thought of the quality of the medical staff. So it is not, so we have to both say it is subjective. It is whether or not I think you're competent and whether or not you're performing or demonstrating authentically competence. So it's not perfect, but it is sure related to a lot of other things that would dovetail and say that there's something important there. And the last thing I would say to that is it should never be used as a defining grade of a physician's competence or skill. But it is a really big part of whether or not patients feel like they're getting their needs met, whether or not they feel safe, and whether or not they trust you.
Awesome. Leah, maybe I'll come back to you, and someone's pressing on something that I think we went round and round on in edits on your essays. Can you say something about the difference in your mind between the legitimacy of the FDA and the trustworthiness of the FDA? Is there daylight between those concepts? And if so, how do you think about it?
There can be. So I think one of the challenges that remains is the variety of definitions, and that comes both from different disciplines and, as you pointed out, trying to find a good definition of what does it mean to trust or what is trustworthiness. And so one distinction we could make is legitimacy as in political legitimacy. Like an elected official has political legitimacy of that office and has a certain type of legitimacy that's different from then acting in trustworthy ways and, fulfilling voters' expectations of them, sticking to the norms of their office when they act. And if they violate those norms, they might violate like a non-political type of legitimacy, like they're empowered to do so, but they've undermined some important normative contract.
Awesome. Guys, we have 3 minutes, so I'm going to ask for like 1 to 2 sentences on the thing you'd like to underscore from your essay or the new thought since you completed the essay. And maybe I'll come to you first, Melissa.
Sure. I think one of the things I'd like to underscore is the structural piece that's really hard to get at in our attainment to trust. That the ways in which research has a 5-year timeline, and that it takes 2 to 3 years to build trust. One of the things I want us to think about in terms of like shifting the dynamic towards gaining greater trust is how do we change the structures? How do we change the institutions? Which is the bigger, existential question, and it's the much harder thing. But I think that's the thing that I want us to get out of, that we have to do more than the superficial interventions. We have to shift the structure. And we can't just talk about how we need to shift the structure.
Thanks, Melissa. I'm going to insert myself here. Mine would be, although everyone is very interested in building trust, I think in some cases we should recognize that mistrust is deserved and we should respect it and not try and change it. Hot take. Art, Michelle, Deirdre, Leah, like one sentence apiece if possible.
Well, I think the only way to get better trust in terms of the communication issue is for the public to see more scientists speaking and more doctors speaking outside their classroom or outside their clinic. So I'm still big on grassroots communication about what science is, about how it works.
Michelle.
I think maybe one of the big points that should be underscored from our essay is that, with, this community organization serving as trusted messengers, that the process is dynamic, and, the trust building that's going on between health organizations and CBOs and community members has to constantly kind of keep going, and it has to be bi-directional as well. Like each party has to feel respected. They have to feel they're being valued, that there's something valued in this relationship, and they're each responding to each other, and that just needs to continue.
Deirdre.
We didn't go into segmentation in our essay, but what I would emphasize is we're often asked, well, are there different drivers of trust or different drivers of likelihood to recommend for different identity groups? And generally what we find is that people all need the same thing. They need to feel safe. They need to be listened to. They need to be respected. They're not getting the same things. And when they don't get them, it can have a differential negative impact on them. So that kind of just, I think, helps us move a little bit forward to don't spend time saying, is this a unique group that has unique needs? Assume that people have some universal needs and it's our job to fill them, and we're probably not filling them already.
I love that, Deirdre. Leah, close us out.
That's a really good lesson for where my question still sits, which is a lot of trust is focused on these interpersonal relationships where we have the opportunity to be in the same room. And it's hard often to then think about how that scales up to something like a regulatory agency. But Deirdre, you remind us that there are some universal shared interests that we can still be working towards.
I want to thank you all so much. This has been just a delight to A, see you all again, and B, get to kind of celebrate the work that we put into this. With that, I think I'm going to close us out and just remind people who are here that a recording will be available and you can share it with friends and family. I know everyone is going to want to put this up over the holidays and make sure their family can tune in. And just once again, thank Hastings Center for hosting this. Have a great afternoon, everybody.
All right, thank you for attending our webinar. A recording will be available shortly. Thanks again.
Thanks.